Good evening, everyone, and thank you for joining us. My name is Michelle Stecklin. I'm an application specialist here at OCULUS. Welcome to tonight's clinical webcast, The Business of Dry Eye Management. You have a text box on your GoToWebinar screen where you can enter questions. Enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our moderator tonight is Dr. Paul Karpecki. Apologies. Dr. Karpecki serves as the Director of Cornea and External Disease at Kentucky Eye Institute in Lexington, Kentucky. He is an Associate Professor at Kentucky College of Optometry in Pikeville. He is the Chief Medical Editor for Review of Optometry and is on the board of the charity Optometry Giving Site. Our speakers tonight is Dr. Crystal Brimer. Dr. Brimer is an expert on dry eye and runs a dry eye equation in North Carolina, a practice that focuses exclusively on dry eye. She is the mind behind the OCULUS Keratograph 5M's Crystal Tear Report and is therefore the perfect person to explain how to utilize the Keratograph 5M to the fullest in your dry eye practice. If you want to learn more about dry eye after tonight's webinar, I highly recommend checking out Dr. Brimer's Dry Eye Institute and attending one of their weekend dry eye retreats. Our other speaker is Dr. Thomas Weshefsky, a 1987 graduate of Pennsylvania College of Optometry. He earned his fellowship from the International Academy of Orthokeratology in 2009 and served on the board of directors of the American Academy of Orthokeratology and Myopia Control from 2009 to 2019. He is the former host of the Academy's Ortho-OK podcast series. He has served as co-host of the annual Vision by Design Bootcamp for beginners and has lectured extensively on orthokeratology and myopia control to doctors from around the world. Practicing in Myrtle Beach, South Carolina since 2006, where he has built a successful Ortho-K myopia control and specialty contact lens practice, Dr. Weshefsky has added a thriving dry eye program to his practice to his practice in 2019. Thank you everyone for joining us, and we'll go ahead and begin the webinar.
Thanks, Michelle. Really appreciate the great introduction. I like this subject, and again, we're not going to have a lot of clinical slides tonight. We're really going to focus on exactly what the title is, really the business of dry eye. And what I like about the way they structured it is you have Thomas Weshefsky, who has had a very successful primary eye care practice, but then focused on key areas. And so, including now dry eye and then previously myopia control. We have Dr. Crystal Brimer, whose focus is on dry eye, or 98% of her practice is that. And then my practice is very similar to, I'd say it's about 75 to 80% dry eye, but all referral based. So I don't see any patients directly. So it's all sent in from optometry colleagues, ophthalmology or rheumatology. Like I have like over 800 Sjogren's syndrome patients as an example. That makes it very skewed. So I think what we have today is really an opportunity to discuss all the aspects of clinical practice and to take it back to your primary eye care practice for those who are doing that, and also those who make it a subspecialty. So we're going to start with going through really from the very beginning. And I'm going to ask Crystal here first. And then certainly, Thomas, go ahead and add in any of your comments as well. But what are some of your challenges and successes? And I always like starting with challenges because I always look and think, all of a sudden they look at you and very successful dry eye practices. They could see the successes, but I wanted to emphasize challenges first and then successes that you ran into in starting your dry eye practice.
Well, as far as challenges, I think a lot of doctors share this challenge because I hear about it from Dry Eye Institute docs. And one of the things is, what do I buy? What treatments do I do? There's so many now that it's becoming more confusing to them as to what do I put in my protocol? What's my go-to? What's my next, my next treatment if that doesn't work? And then the other big challenge is time and fitting it into a primary care practice, and how do we do the scheduling and the flow where the rest of the practice is not suffering and where we don't inhibit the flow in a manner that disrupts staff support, or they're not on board with you anymore because you're disrupting the flow and slowing things down. So I think that was a big challenge. And as far as one of the successes in meeting that, and we could talk about that for an hour alone, but one was in making that declaration that we're going to screen every single patient that walks through the door. And I know we're going to talk about that a little bit later, but it was one of the things that created a success for us and for many other practices that I know, because it created that momentum of drawing more attention to the dry eye and then creating accountability and actually taking care of it. So one, screening every patient. Two, really dealing with the questionnaire ahead of time. And I don't mean a speed or an OSDI. I'm talking more about when they're coming in for their dry eye eval, getting that extensive history part out of the way so it didn't delay the flow. And then optimizing the scheduling and optimizing the patient education part again so it didn't delay the flow. That's one of the things that helped make it a success instead of a challenge, or turn that challenge into a success.
That's
and
excellent.
I would say on the success end, one thing that I always talk about and I believe in wholeheartedly is when you do that and you're really focused on those outcomes, the rest of the success just flows so naturally. And that's the fun part, is when you're focused on that patient education part and building that compliance, then as long as you know what you're doing, the outcomes are going to be there. And once those outcomes come, then you've got the growth and the revenue and the referrals and everything that follows.
I like it. Thomas, you're a little different. You started in, certainly, myopia, orthokeratology, got really known for that. And then what kind of drove you into dry eye, and what were some of their initial challenges being in a primary eye care practice?
It's a great question, because for me, it was really all about the ortho-K, myopia control, specialty lenses, and moving to Myrtle Beach has become really a retirement community. And so that wasn't really my patient base. They weren't really, it wasn't applicable to most of them. And I started looking at, what else am I going to do? And because I really believe in specialty care, it's really kind of the holy grail for all of medicine, not just optometry. So really, dry eye is anterior seg. It's where I've spent most of my career. And I started looking into dry eye. I'd been treating it for years, but it was always very frustrating because, what was the treatment? It was going to be hand somebody some artificial tears or some plugs, and really not get much in the way of results. So seeing what was starting to happen in 2018, shortly after dry eye became classified as a disease, I realized that was where the opportunity was. That's where my patient base was. And the biggest challenge was, well, how do you set this up? And that's actually where Crystal came in for me, because I did Dry Eye Institute, and it was hugely impactful for me. I think that's probably the first step that anyone should take, is to get yourself educated, not just in what is dry eye or the clinical aspects of it. Sure, that stuff is important, but how to make a business out of it and how to implement it in a practice. So the implementation was what I was really big in ortho-K and myopia control. And so going to someone who was an expert at it, like Crystal, was really, really probably the biggest challenge up front, was to find that person. And that was probably my biggest success in getting started, was getting a game plan. It's very easy and I see this happening a lot with a lot of docs. They're becoming enamored. They see something about IPL or low-level light therapy or radio frequency, and they're going out and purchasing these expensive devices, but they have no way they don't have any clue how to implement it in their practices, and they're running into issues. So I think you need a plan first.
Makes sense. Yeah, I can relate to some of that, Joe. So I started my first dedicated dry eye clinic, so I was way off in 23 years ago. When you're right, 2018 might have been the time that it got exciting and people started recognizing this as a disease. I was doing this in 1998. And, and to be fair, it was frustrating. I remember days when half the patients would come in and say, is there another doctor I could see? Can you imagine going to work where half the people don't think you have a clue what you're doing? But I felt like there was always something there that could kind of lean towards the potential. You get kind of like when you golf and you hit one really good shot and you're like, wow, there's something here. I could get back to this. All you need is that one. And that was kind of what it was like back then too. Today, You know, and again, I need to put this in perspective. I mean, I see 60 patients in a day, all referred in or follow up. So it's a very unique setting, but we have about a 96% to 97% success rate based on patient response. So it's amazing what we could learn over time, from going to where half the patients thought you had no clue what you're doing to, I mean, even over the holidays, our staff, I tend to give all the gifts to the staff, but this year we got so much good bourbon, I had to keep some. But the point is, the patients were so happy with their results and so excited by where they're at. And that's hopefully what we'll convey today too. But, you know, it's good to have, you know, 3 different practice settings. While there's overlap between all 3, you know, you may be at different stages of where this fits in. So Crystal and Thomas both mentioned screening for dry eye disease. You know, how do you, and you said you screen everybody in clinic. Tell us how that works.
I'll start, Tom, if that's okay. I have quite a passion for this, or quite a concrete idea in my head where maybe I'm not as willing to compromise, and you could change my mind if you have an opposing view. I'm willing to listen. But when I started this practice that I'm in now, this was back in early 15, and I knew I wanted to do dry eye. Well, everybody had new patient paperwork and they had so much to do, and I didn't want another questionnaire. So I was already against speed and OSDI at that point, just because I didn't want more paperwork, because we were a brand new practice. So then it kind of built from there. But what I learned is, when a patient comes in and they do a questionnaire, and don't get me wrong, if you're not doing anything now, then get a questionnaire. It's a fine place to start, and it's absolutely better than nothing. But if we're comparing the alternative, and we're comparing a questionnaire that's subjective, and the patient comes in and they've listed out some problems, and you look at them and you're like, oh yeah, we got a problem here, and I'm going to need you to do, you know, some warm compresses and some scrubs, and I'm going to need you to come back for this light treatment, and we're going to have to evacuate some glands, and you know, it keeps adding up, and they're thinking, yeah, it's not that bad, right? Because they think that what we're recommending is based on subjective complaint, or worse yet, they do some of these things and then they feel better, and so they stop because they think it was on subjective basis. Whereas if I screen with my 5M, and I'm typically doing the redness score, the interferometry, and the tear meniscus height. So I'm doing basically water, oil, inflammation, snapshot. If I do it with that, then we're basing these recommendations, these diagnosis, recommendations, and treatments on objective findings and not subjective. And so then we're constantly able to remind the patient that you don't stop when you feel better, because we want to prevent this from getting worse, and that it's not just about, oh, if I feel bad enough, then I'll do it. So bottom line, we screen everyone, and we use an objective measure in just those 3 quick tests. It takes 1 minute from the time they put their chin in the chin rest until we're printing out the report.
Makes sense.
And I will say, if no one's else going to talk, you know, I'll just keep talking.
Wow. Thomas, do you have a screening questionnaire as well, or do you just do you also use the Keratograph for your screening?
Me? Yes.
Yeah.
I use the Keratograph for screening. We screen every single comprehensive eye exam patient. We don't charge them anything extra for it. It's part of their pre-test procedures. We're doing the 3 images on the Keratograph that Crystal mentioned. We had a 4th, we had redness score. So again, to capture those images, between adding their name into the Keratograph software, capturing the images, with maybe 2 minutes total that it adds for the technician in their preparation of the patient to see the doctor. I don't do any comprehensive eye exams anymore. My associate does that. When she is examining the patient, they're pulling up these 4 images up on a 32-inch flat screen, and it's pretty easy to see where there's an issue. And she'll just say, look, I can see by this that your eyes are red, that you have some gland dropout, or we don't see any lipid layer, or the tear meniscus height is low, whatever the issue is. I'm going to recommend that we get you back in to do a comprehensive dry eye evaluation on you, and she'll have them scheduled to see me for their next visit. we don't go into any dry eye treatments, anything at all during their comprehensive exam. That's really what we're doing just to get them to come back in for their dry eye evaluations. And I got to tell you, unlike Crystal, I don't use a questionnaire. We don't even ask them questions about dry eye. I think one of the biggest things that I've heard from so many optometric educators that I really just can't agree with is a lot of them just said, well, it's not worth just screening every patient because the yield isn't great enough. And I would absolutely differ on that, because I would tell you that the majority of our dry eye patients don't come in complaining of dry eye. First of all, most of them just think it's a normal consequence of aging. And a lot of them think, well, I'll tell them I have dry eye. All he's going to do is hand me another bottle of artificial tears like the 4 other doctors prior to this. So there's really no sense in, and they won't mention it. That really is difficult to get out of them initially. And once you show them something, as Crystal said, objective, then the subjective complaints may start to come in. And when they come back in for the full dry eye evaluation, again, we're doing an OSDI on them, but I don't use that so much for their evaluation. I'm using that more, I'm showing them all the objective tests that we're doing. And then when they come back later on after we've treated them and they're improved, and I say to them, well, look, you've gotten better. Well, yeah, but I'm still a little bit dry. Well, subjectively, your score was 58 before, and now it's 13. So yeah, you're definitely feeling better. And so I use OSDI or any of those validated scoring systems a little different than most.
Yeah, I've always been intrigued by the optometric dry eye summit. I think it was in 2014. It was like 30 of the docs who were really into dry eye at the time got together in Denver, and they talked about these 5 questions you should ask, maybe from the front desk, or they're screening questions, but they're really meant to help identify some of the patients. And they're basically, how do your eyes feel? So there are things like, are your eyes gritty, dry, burning, that sort of thing, kind of the feel. How do they look? Are they red, irritated, which again goes to maybe doing the keratograph and mentioning that. Do you have the urge to, or are you using artificial tears? Do you experience fluctuating vision? And then how much time do you spend on digital devices? Even though today everybody spends so much time, you might not ask the last one. It does kind of allude to a patient to recognize that if they're spending a lot of time, maybe they do have dry eye disease and they need to watch for that. I always thought that'd be a good place to, ask, from the front office when they're, scheduling an exam. They might ask, that might take maybe 10 or 15 seconds to ask those 5 questions. It really kind of isolates this potential for dry eye, and then say, the doctor will evaluate you for that. And then of course you could set up your regular dry eye exam. And I think that's really important, is to have that on the medical side, to be able to set it up where it's at. In my clinic, they're already referred in. So I typically, when I look at them, I just ask, what's your worst symptom and when is it worse? And I have an extensive questionnaire, but that's based on everything from, graft versus host disease to, symptoms for neurotrophic keratitis, or lack of symptoms, but maybe predisposing factors, I should say. And it's more in that regards. But I like those 5 questions. How do your eyes feel? How do they look? Urge to use, are using artificial tears or re-wetting drops? Do you experience fluctuating vision? And then how much time are you spending on digital devices? And I think, you got to be careful though, because you might identify so many patients, it's difficult to set that up. So speaking of setting that up, let me start with Thomas this time. How do you set up your scheduling? You're not doing primary care anymore, neither really technically is Crystal. She's really focusing much more on the dry eye clinic. But how do you set up the scheduling? Do you have certain time frames? Do you set up something slightly different for new patients? Procedures, do you do those on separate days? What's the best allotment for that for these colleagues that are listening in today that want to build a dry eye clinic?
I would say they definitely have to have, some time that is not mixing with primary care. It's really difficult to shift gears. Today, for instance, my associate was out, so I had to see her primary care patients in between my dry eye patients. It's a tough schedule when you're doing that. Typically, I don't do that. Typically, I'm only doing specialty care at all anymore anyway. So the days that I'm seeing dry eye patients, they're scheduled in for a 45-minute visit. If it's someone who's been referred in by another practitioner, I might give them an hour. You know, it depends on how difficult they are. If it's just the people that we've screened already, we already know a lot of their history, and so those are 45-minute visits, and that time is split between me and the technicians. So typically, it's going to take them about 15 minutes, maybe 20, to collect all the data, to capture all the images, and we're doing a series of, we're usually doing 9 or 10 different images on the keratograph. And I'll pull up all those images in the exam room and really use those images to tell the story of their dry eye. And, you know, when you look at these things enough, you can pretty much tell them what their symptoms are. I mean, you can see that their breakup time is 3.5 seconds. You know that they're getting fluctuating vision. And so again, as Crystal said, it's really using objective means to validate their subjective symptoms rather than the other way around. And that's where you get the buy-in, you know, when they're seeing that, oh yeah, I am experiencing that, and you can show them why it's so by explaining. I mean, I use those images sort of like show and tell, and it's a whole lot different when someone sees their myopography and their gland drop out, and you tell them they're going to need something like IPL or low-level light therapy or some expensive treatment. You're going to get a lot more buy-in when they can see it and use those images to show it to them.
Yeah, I agree. Crystal, quickly, do you have certain amount of time for technicians versus your time? How do you differentiate that?
Well, I would mirror what Tom said on that. The only thing I would add is that what has helped me and a lot of doctors get started is that dry eye evaluation when you bring them back. Schedule no more than 2 a day in a normal day as you're getting started, and do it last before lunch and last before end of day. And that way your keratograph is not being held up in a dry eye eval when your new rule is to screen everyone. So it's available, but also it allows the doctor to get their verbiage down pat and their flow down pat while they're new at it, so that they're not worried about how many people are waiting in the waiting room, and they can run over if they need to. That, and when you ask the question about frequency of follow-ups, it depends on if they're doing a procedure. 90+% of my patients are doing a procedure, so my very next visit is going to be as fast as we can get them in, which is not that fast, but it's going to be for that IPL number 1, 2, 3, and 4, and those are 30-minute visits, and I do the visit and the IPL. And then after that, if they're obstructed, they're going to come back for evacuation. If they're unobstructed and happy, it's going to be 6 months later. If they're unobstructed and iffy, it's going to be 3 months later. If this is part of the 10% that chose not to do a procedure, then I don't want to see them again for 2 months, because it's going to take time for the initial treatments to kick in, and I'm not going to change anything if it's within that 2-month period. And then, you know, we keep adding treatments and waiting and adding and waiting.
Makes sense. That's pretty good on that regards. And I guess you know, for me, I don't screen because they're being sent in already, but I will do on every new patient, obviously, a keratograph and collect all the key images, be able to use that, as you both said, for teaching. And I think that goes extremely far when you're trying to then convey a treatment option for them. I mean, if there's corneal staining, I'll typically start with a steroid, so I'll probably bring them back in about 4 weeks, check pressures. If they're responding well, I might switch over to something else, immunomodulators. If they're not responding, I might go to a biologic of some source, you know, whether that's, you know, amniotic membrane, serum tears, whatever may be playing. And I agree, you know, procedures really play a key role. But fortunately, I have, you know, staff that scribe and staff that do the procedures. And it's good to hear all the different varieties here. And I have staff that practically put the fluorescein in. I mean, I'm so spoiled, gosh. I don't do anything. I sit in the chair. I spend 3 to 4 minutes with the patient. I go over the images from the keratograph of what I'm seeing, why I'm concerned, what we're going to do. I discuss the treatment, then I hand it back to the scribe who carries them through. Here's what Dr. Karpecki wants you to do. And then it goes to the procedures room. where they discuss it, and their conversion rate's high, probably around 90% as well. But I just talked about why I like it, that it's not insurance covered, but why this will be the best treatment for them, and they're able to then take it to the next level. But I think it's good to hear multiple approaches. Mine may be the furthest from primary eye care, but I love what I do. I love the opportunity. I'd love for you to get to that point. I think you're going to find it might be one of the most enjoyable things you can do. So it's a good process, but I do think, you know, what Crystal and Thomas are describing is much more practical for primary eye care, and probably much more likely to be implemented very successfully. And so it's just good to have that variety there. So we talked a little bit about practice flow. You know, one of the things I'll bring up real quickly on the next question is I do tend to schedule my procedures other than IPL, because I'm not doing those, or thermal pulsation or blepharoexfoliation. Those are being done while I'm seeing patients by a technician. So those are already getting taken care of. But if it's a amniotic membrane, punctal plugs, something where it would take me time during the day, concretion removals, things along those lines, then I'll schedule them on a separate procedure day. My Fridays are my procedure days. If I have to fit amnion, at least they have it in their eye till Monday. You know, they can take the weekend off. So I do schedule procedures on a completely separate day, except for the ones that can be done by someone else in my clinic on the day I'm seeing them. Do you guys you said, Crystal, you go ahead and do the IPLs as well, during the course of the day, you just have to watch your scheduling, is that right?
Yeah, I mean, it honestly, it doesn't add that much time. I mean, I'm still there, but I have a 30-minute time slot between patients, and I'm able, someone else is doing the acquisition and the workup. I walk in, I show them the pictures, I debride, I express, we do our IPL. It seems to be that there's plenty of time.
No, it's good flow. Thomas, yours are done during the day as well, or are you scheduling in other times?
So I'm not doing a lot of those treatments. I found that it was really getting to be difficult for me to maintain, because I have unlike Crystal, I don't have a specialty I have a subspecialty practice, but it's within a very busy primary care practice. So I'm probably seeing a lot more patients per day, and I found that replacing me to deliver the treatments was just far more effective for me. And so I have my technicians doing that. So I don't do IPLs or radio frequency or BlephX. I have a technician that does all that. And, you know, I've had to add staff, but adding dry eye has enabled me to add that associate to do all those things. You know, after all these years in practice, this is my 36th year, I don't want to do everything anymore. I don't love certain things, like I don't love doing glaucoma. I like anterior seg stuff, and if I can just spend the remainder of my career doing just the stuff that I really enjoy the most, that's kind of the way I would like to do it. So yeah, I pass that off to a technician in the office, and if she has any questions or difficulty, and she's actually very good at it, so I don't have any issues. But if, you know, on occasion I'll do a treatment, but most often I'm just doing the evaluations and the diagnostics and making writing the prescriptions for it.
Yeah, we're pretty similar there, unless it's just the amniotic membrane or something where I'll fit those or place them. I agree. That works well, and honestly, my technician does a better job, I think, than I would ever do. He is a little more patient, takes the time. Let's go back to the Keratograph. You kind of mentioned this earlier, but we may just real quickly go through what you think are the most important tests you acquire. So this might be a little repeat of what you started with, but let's start with Crystal this time. You know, for your patients you're seeing, what are the tests you feel are most powerful that then you can discuss with the patient? And I know you mentioned inflammation, you mentioned lipids, and you obviously mentioned, you know, the tear volume or the aqueous deficient component. Is that encompassed in 3 tests or more images?
So I would put this in 3 categories. So I don't screen people either, because all of my patients are referred in. But when we're screening, or if you're going to screen, those three: water, oil, inflammation. So tear meniscus height, interferometry, or if you want to do NICBUT, it takes just a minute longer, but it's nice to be able to associate it with vision dysfunction, because you can explain how the Myers are getting distorted, and that's their view looking out. And then the third one of redness. So water, oil, inflammation on my screening. On my follow-up exams, I do that same water, oil, inflammation, but I like to have tear meniscus, tear film dynamic in there, so we can look at all the junk in the tear film, because I find our conversation is very frequently coming back to that as being a source of redness or a source of, adding to the corneal staining and that sort of thing, and then looking at where that debris is coming from. Now, with that being said, I have different types of follow-ups. So if it's a corneal eval, then there's also going to be fluorescein staining and a fluorescein video in my work list. If it's a lid follow-up for blepharitis, then there's going to be upper and lower lid images in my work list. But all of that is set and saved ahead of time. So all I have to do is say, what kind of appointment am I bringing them back for? And now my technician knows exactly which work list to pick, and they're going to get every picture that I want taken, and I don't have to route them back through. Now, the third kind of exam is the dry eye eval. So the patient's been referred in, it's the first time I'm seeing them, and I'm doing the whole gamut of tests. So it's going to include those, basically the tear meniscus, the interferometry, the redness, the tear film dynamic showing the debris, the upper and lower lid images, the fluorescein picture and the fluorescein video, so I can show partial blinks, I can show tear film breakup time, I can show staining, and then I also do the lysamine green staining as well, so that I can do line of marks, lid wiper epitheliopathy, and I flip the lid, I do a palpebral conj pictures upper and lower, and I do my biography upper and lower. And that is my full dry eye eval workup on the keratograph. The only thing I add to that, and quite frankly, the only part of the exam that's missing, is debridement, corneal sensitivity, debridement, and expression. And so I film those on my other anterior segment camera and add it all up, and I show them everything.
Tom, what's your key keratograph images that you use?
So I'm doing almost the exact same thing that Crystal is. When we're doing a complete dry eye evaluation, we're doing the tear meniscus height, we're doing a NICBUT, we're doing the interferometry, it's the dynamic tear film video, we're looking for the lipid layer, we're doing a redness image, we're looking at the lids, both upper and lower, we're doing my biography. But since the techs are doing it, and I haven't seen the patient yet, I do not want them putting any vital dyes in the eye yet, because I want to see that. And so they're going to capture those images, and then the patient will be brought into the exam room. I'll review those. In the exam room, I will use my vital dyes, whether it's fluorescein or lysamine green. Usually it's both. And I do have an anterior seg imaging video slit lamp, and I'll video that. I'll express their glands. I like using the meibomian gland expressor, the one from J&J Vision. It's spring-loaded to deliver the approximate amount of pressure that you can get from the maximum pressure you can develop with a blink. Like showing them what's coming out of their glands. And I find that's really powerful for the patient when they're seeing, they're getting toothpaste coming out of those meibomian glands. That's to get it, and those are pretty much all I'm doing. The rest of it's pretty much the same as Crystal.
Well, I'm I guess a little different than the crew. I'm a little biased to the, TFOS's diagnostic methodology. Because I was on the committee, but also, I mean, to be fair, everybody contributed a lot on that committee, and it has about 700 plus references, but it carries a lot of overlap to what you're doing. When the patient presents in my lane, I guess I'm a little close to Tom there. All the imaging has already been done on the keratograph that I'm looking for. I just simply ask the patient, what's your worst symptom? What time of day is it worse? And then I look at the, you know, the non-invasive breakup time is kind of quick. I like that one that Crystal mentioned. I also don't like fluorescein in the eye until I see the patient. For that reason, we have, you know, an eye care tonometer, or so we don't have to put fluorescein in to check pressures, because many patients are on steroids as far as their follow-up, but I still want to be able to have the fluorescein at the time I'm seeing them. We will look at osmolarity. I think it's a good diagnostic tool for kind of the non-dry eye cases. And then when the fluorescein is in the eye, like I will do, when I see the patient, I will ask that question. I'll do an extensive lid exam, upper eyelids, lower eyelids, have the patient look down, look for collarettes, look for telangiectasia, the eyelids. And then I do express. I like the Mastrota paddle. Maybe in my clinic, I don't get as much expression with the MGE, the meibomian gland evaluator, but I think the meibomian gland evaluator is probably better in primary eye care practice, where you're looking at all various patients too, because it mimics the exact pounds per square inch of a blink, so it's much more accurate. But I like just the Mastrota paddle because I'm so used to it. I've had it for like 13 years, and I just know how to push up the nasal central glands, tell me what's going on. And then with the dye, I look to see if the tear meniscus height is. I look at the keratograph to be able to show them the height of it, of where we're at. And I agree with both of you. I like meibography on lower and upper. It's already there, sitting there, and I can show the patient where they should be and what they truly are. But that way I've got dry eye diagnosed because they have symptoms and they have signs like a breakup time. Breakup time doesn't tell you the type of dry eye, but it does tell you they have it. Osmolarity doesn't necessarily tell you the type, but it tells you they have it, and even staining to some degree. But with a low tear meniscus, I know it's aqueous deficient, and with poor expression, I know it's evaporative. So that can all be carried through, as we mentioned, with the keratograph, except for very similar to you, Tom, where I'm, you know, you're imaging and you're taking a video of the expression to show the patients. And then from there, I could decide where to focus my treatment. Is it evaporative dry eye, where the meibomian glands need to be the focus, or is it aqueous, where I need to work on the mucin-producing goblet cells or lacrimal glands, or is it a mixture? Let's hit the next question, because I want to get a little bit more into the Crystal tear report. And this one, of course, Crystal, I'm going to target with you. It's been a very valuable tool for so many clinicians. Can you elaborate on how you use the tool with your patients? I mean, not just the images, you went over that really well, both of you, but how you use the actual tool of what you can select and how that works in your practice.
So in reference to the actual printout, we use it for 3 ways. Back when we were doing screenings, before we were just referrals, we would print out the screening report. And I liked it because it had those 3 tests, and it had kind of a paragraph, an intro of you may have symptoms, you may not. Either way, this could be progressive. And so it really was a nice introduction for the patient, so that if they were contact lens wearer and they disappeared on you, but later on in the year they felt something, they knew where to come back. That aside, we don't do that too much anymore because of our situation. Now we use just the full report, and it's primarily on the dry eye eval. And we use it for 2 things. I will do, my tech does all the acquisition, and I come in, do the debridement, the expression, the corneal sensitivity, and then talk to the patient, show them all the pictures. I turn around and put my notes in my EMR documentation, and then she goes into my EMR and into the viewing station on the OCULUS 5M, and she fills in all the bubbles. So she's the one that's actually grading all of the report based on what I've documented in my chart. And the reality is, I don't care if it's a little bit off. It doesn't matter to me. The point of this report is to engage the patient. And so when they leave, they have a very extensive, tool in front of them that's going to be a resource to show them what are my primary problems. So it's got a pie graph, basically prioritizing their issues. And then for each of those issues, it shows them which tests were done, how they scored, the definition of the test, the treatments that are paired with that particular diagnosis. So one of the primary uses we have is to hand it to the patient before they walk out the door. And this is also important because as far as billing, it allows us to bill for this out-of-pocket expense for a dry eye eval, where it's not overlapping with time that we're billing to insurance or anterior segment photos, things like that. Now, the other reason that we use it and we value it so much is once that report's made, it goes back to the referring doctor that sent the patient to us. And, you know, there were times where we were understaffed like everybody else, and we got lax on this and reports were not going out. And we made a line in the sand where we said, no more. Every single dry eye eval that's referred to us is getting a report back to that doctor, a crystal tear report specifically with the letter. And when we made that commitment, our referrals went up. And it was just very directly proportionate to those reports going out consistently compared to what we've been doing before.
That's great. Let's go into treatments. Tom, I'm going to address this to you first, but so you've got your patient, you've made a little bit of your decision on perhaps the dry eye and what you're going to target. Do you have an algorithm you follow? Is it something that you just know to how to manage these patients as far as the treatment options for them?
So first of all, thank you for not asking me to follow up on Crystal with the crystal tear report.
I figured that was definitely hers.
Yeah, I'm happy about that. So yeah, we, you know, depending on what their dry eye is coming from, and I explained to them at the outset, the whole purpose of all the screening that we're doing is to hone in on the root cause or causes. And typically, the treatment algorithms that I'm using, if there's any kind of meibomian gland deficiency, we're going to be looking at something nutritional, whether it's an omega-3 or some other nutritional supplement. We want to add some sort of homework. I try to minimize that for some patients. So lid hygiene is always going to be a portion of what I'm going to recommend, and whether it's using a tea tree oil based foaming cleanser followed by hypochlorous acid, whether there's going to be hot compresses. Typically, I'm going to recommend a heat mask, not just a hot compress. And then in terms of treatments in the office, if I think there's a lot of inflammation, my go-to is always going to be IPL, especially if there's rosacea. But even in the absence of rosacea, I'm still going to favor IPL. The difficulty I have with that is because I'm in a largely retirement community, because I'm down south and everybody's a retiree from up north, all they're doing all day long is playing golf or going to the beach. And with IPL, I can't always rely on that because of the photoreactive effects of it. So for those patients, I might be doing, you know, more of low-level light therapy. I really have incorporated that in a large way in the office. We also do LipiFlow, and we're going to also be doing some form of BlephX, or some expression and lid cleaning within the office.
That's great. Makes sense. I love it. I mean, I think it was a great answer. So let's take that a little further, Crystal. None of these are covered by insurance. Patients will ask that a lot. How do you approach these in-office procedure costs with your patients?
The only cost that I tend to spell out in the exam room is IPL, because I feel like when I'm going through the pictures and then I say, okay, let's prioritize our issues. Our number one issue is, and it's usually inflammation and oil. And then our number two is, and I'll say what it is, maybe we've got a little problem here, and I'll go through each one and I'll say good, better, best option. And when I get to the inflammation, I say, all right, good, it's going to be the lifestyle, the supplements, the getting better sleep, eating anti-inflammatory foods, blah, blah, blah. The better, we've got all these drugs, and we go through that. Best, hands down, is IPL. And I walk through the value behind it of, its origin and why it's a good choice. And then I'll say the only downside is it's not covered by insurance. And it's going to be X number of dollars over the course, times 4 over the course of 4 months. And the reason I do that is because I don't want them necessarily to find out up front when it's not as defendable as being right in front of me, when I know that I can create the value around it in a more substantial way, because we're talking about the benefit and then here's the price, as opposed to them getting in a different scenario where it's just price. And we write out all this verbiage stuff and the scripting on all of our products and all of our treatments. It's part of the Dry Eye Institute resource. So my staff knows it and they should be able to do that. But still, there's probably a little bit of extra micromanaging that I do here in doing that. And that's just me. Sorry.
Actually, it's not just you, Crystal, because I do very much the same thing. When I know it's going to be an expensive treatment protocol, I don't want them, getting up to that front desk and getting sticker shock. Well, it's not that bad, I don't need it that much. So I will do very much like you do. I'll tell them in the exam room, look, this is, I want to be upfront with them so they're not surprised when they go to check out. And I want them to know what to expect.
Well, and you get to know what their decision is. I don't want them getting up front and the patient and my staff deciding what the alternative is. I want them in charge of that in the exam room. And we've been able to help with that in certain ways. We've got a nonprofit that helps with advanced dry eye procedures, and that's given us a lot of freedom in working around. But that's the other thing I tell patients is there should never be something that stands in the way of you getting an outcome. And so if there is, you've got to tell me because we can help you work around this. And I think just keeping that communication open as you're talking about the price.
Yeah, I guess we're all similar. I always bring it up too that, that I give talk about the advantages and I say the disadvantages are it takes 4 treatments because the intensity has to be divided and it's not covered by insurance. I think it is good to be straight up. I also find that, by going into a little bit of the, the other options too, LLLT, giving them other choices. I'm a big fan of those as well. Does help. But I am going to recommend what I think is most effective for them. And speaking of that, if you had, multiple components, say you had inflammation and aqueous deficiency and meibomian gland dysfunction. Now, those are certainly rarer, but sometimes long-standing Sjogren's patients, the meibomian glands kind of overwork and they break down as well. They're running the marathon every day. How do you address treatment without making it too complex?
Well, if I've got all of those things going on at once, I'm typically going to address the lipid issues first, or really lid hygiene is always going to have to be a huge part of it. And so I'll do that simultaneously with the lipid issues. And then sometimes that's enough, if you can get things squared away there, that may improve the aqueous issues and you find that you don't need to treat the aqueous. The other reason is if I'm manipulating lids and I'm expressing glands, I don't want to put in a plug at this point. I want to wait till I've cleaned up or improved the tear quality before I try to plug anything. So I'll typically just give them some artificial tear to use in the interim before addressing any aqueous deficiencies.
I tend to treat everything at once, but not to the same level. So basically, if I've got 3 or 4 categories of issues, I want to get something started in each category. If I've got a lot of inflammation and I've got MGD, I'm going to do inflammation, my bigger treatment there first, because a lot of times it will take care of the MGD and get the oil flowing. But it doesn't mean I'm not treating that. I'm just treating it with more at-home stuff and putting off the in-office evacuation to see if we will absolutely have to have it. But I think simultaneous, but yet preparing them ahead of time, that it might be cumbersome in the beginning, but this is not going to be forever. You come back, whatever's better, we can back off. If it's not better, we go up to that next level. And that way, you know that we're always doing the least amount we had to do.
Yeah, no, I think it makes sense. I try to, address their key problem first, but I don't want to neglect other problems. Like if there's staining, I think steroids are a better first approach just to see what response we're going to get. I also feel like, if there's a mucin deficiency where I'm seeing conjunctival staining, there's no downside to using a vitamin A ointment at nighttime. I also, want to address something with the oil gland. So I'm a little closer to you on that too, Crystal. I feel like I want to kind of hit a few high points, but not overwhelm the patient with options. But that's where in-office treatments can help. I mean, if they're not going to be certainly, continue to use the products I recommend at home, then that's when I do recommend an in-office treatment. And those seem to work well in their understanding that if I'm not compliant with products at home, hey, is there something I can do in the office? And that promotes that aspect of it as well. So I agree. I think we're similar in many fronts of both of you of how we address the key things, but not to try and overwhelm. Let's jump up now to kind of hit this one of at home real quickly. Let's hit the next one. What is the conversation that have with patients in order to manage patients' expectations after treatments? Not every patient gets the results in 4 IPL or after an LLLT or a long-standing chalazion after an LLT, although they improve, maybe if they've had it for a while, it doesn't go away. Obviously, Hordeola usually do with that, or even LipiFlow or BlephX. How do you address that? Do you add in things like neurostimulation or recommend other products to kind of help them go longer? How do you set the right expectations for in-office treatments?
One thing that's helped me a lot, Paul, is explaining from the beginning, the very first dry eval, that A, we're not curing anything, B, it's going to take a couple months, 2 or 3 months for us to get there, but that because we're not curing anything, it's all about extinguishing the progression and figuring out what the least amount we have to do to maintain. So, we put that out there, but I also really draw attention to the lifestyle part and the fact that if your body's inflamed, your eyes are going to be inflamed. And so I ask you about stress, anxiety, depression, diet, hydration, systemic disease, all this stuff, because those are things that drive inflammation. And so we can treat this topically with fancy in-office treatments, at-home treatments. We can do it all, but to some degree, we're going to be capped at how good we can make it if we're having systemic inflammation driving this local inflammation chronically. And so what that does is it changes some of the onus. They're not looking to me for a magic pill or a magic procedure. And when we come out of that procedure, they still know that there's responsibility on them to really make it a home run. And so instead of them coming in upset with me that they had a flare after spending money on a procedure, they're coming in more of as a confessional going, well, they felt bad for the last couple of weeks, but I was on vacation, I was eating, I was drinking, I didn't do my stuff, and it's more that we're a partner in this and a team in getting the outcome. That, and then I also say, when I'm doing my good, better, best, when I do this in-office treatment, the majority of the time, it keeps us from needing more chronic treatments like prescriptions. Not all the time, but we've got a good chance. And so they already know in their head, we're going to do this because it's the appropriate order to do it in. But there's a percentage of people that still need amniotic membrane. They still need immunomodulators and other treatments, even though we've done the in-office. But I think it's important to tell them that from the very beginning so they don't look at it like a fail.
That's great.
Absolutely. I mean, one of the things that I really have, after all these years of doing this, is if we're doing something like LLLT or IPL, I know they're going to need to be treated again in the future. I've done my own sort of clinical trials. I've let people go for 3 months, and at 3 months, they're all doing fine. At 6 months, they're all doing mostly really well. At 9 months, to me, there seems to be something between 6 and 9 months that patients almost fall off a cliff. And at 9 months, a lot of them are still very symptomatic again. So, if I've done a series of IPLs or LLLTs, I'll typically want to bring them back at 6 months and just do a single booster treatment just to keep them there. And that seems to be working really, really well. It's keeping patients from backsliding. I mean, I also have them doing their homework. They're still doing their scrubs, and they're still doing their omegas, and just like Crystal said, they sometimes fall off the wagon, and they'll come back. And even my own sister, I put her on scrubs, and she was doing great, and she lives 6 hours away, and I speak to her on a regular basis. She said, "Dom, I'm doing fine," and she came in to see me like 9 months later. I said, "So your dry eye is good?" She said, "No, it's terrible." I said, "Well, really, why? You've been doing the scrubs." "Oh, no, I stopped doing those." "Well, why did you stop?" "Well, I was feeling better." You have to explain to them this is something they're going to be doing ongoing. And yeah, I mean, that's how I've been handling those expectations down the road.
Yep. No, you're right. I tell my rosacea patients, the good news is, although we have to do a series of 4, the next time we'll just have to do, and I use the term booster as well. And typically rosacea is about 6 months. Non-severe rosacea, patients who had some expressibility, it is really in that 9-month time frame. You're exactly right. And for me, what's interesting is it seems cumulative, meaning, if let's say they made it to 9 months, even though they're doing all the at-home things, that single booster will often get them to 12 months the next time. And then it may get them to 14 months. And it's interesting how that perpetuates, but it's all expectations. You're exactly right. And knowing they have to do their work as well at home to try and keep it going. And that may allow them to go a little longer, but I think those were great answers for that. Let's get into this really common question. Doctor on the call today, listening to this and all your insights around the business of dry eye, buys the Keratograph M5, but their thought is, he or she is saying, how do I make this, I get a return on this investment? If I'm going to put this kind of investment in, how do I make it work financially? What would you say to that, doctor? Let's start with Thomas this time and then go to Crystal.
So for me, when I decided to really get serious about dry eye, I attended Crystal's Dry Eye Institute, and but I purchased the Keratograph 5M. Now, I already owned 3 other corneal topographers. I didn't need another topographer. I bought it specifically for its dry eye capabilities. And there are a lot of devices out there that can capture images, but I've never seen any other device that could put these images together in allow you to explain this in such a clear, cogent, and concise manner that I really credit the 5M with getting my entire dry eye program off the ground, because that's what getting the buy-in for the patients. So for me, when I knew I was going to be doing this, I had probably about 50 patients lined up in advance waiting to come in for complete dry eye workups. And so that Keratograph was paid off in about a month and a half. The Keratograph and the M22, which was the IPL I bought at the time, that took me about 6 months to have everything paid off. So it's been the biggest single modality that I've ever added into my practice in terms of return on investment, because there is there's very little in the way of insurance coverages, and the average case size is usually substantial financially.
So very quickly, I'll say, you think about diagnostic pieces of equipment, they don't usually generate revenue. You think about an OCT and you're getting reimbursed $34 a piece, and it was $35,000 or more. I've run these numbers before with the 5M, and if you did 1 dry eye eval a week at $99 and 6 photos a day, it takes 8 months. If you do 2 a week and 10 photos a day, which is nothing, it's less than 4 months. But the reality is, it's not, first of all, that right there is unusual to have a diagnostic piece that can generate revenue. But it's not about that, it's about the buy-in. And so it is nearly impossible to really calculate how much money it can bring in, because this is the piece that creates the buy-in to whatever treatment you are asking the patient to do. And better yet, it keeps me from being a salesman. I don't ever feel like I'm selling. All I'm doing is the messenger, and I'm showing them their story, and I'm telling them their options. And now we're choosing together the best option for them. But because of this device, it creates the compliance, which gets the outcomes. So even if I tried, I couldn't go back and say how much revenue it actually brought in, because it's immense.
Yeah, that's really well said. I think as you build your dry eye clinic, it's all part of the package of what makes this successful financially. And as a whole, I have heard of practitioners, though, charging an advanced diagnostic fee, their dry eye patients, something nominal, 30, 40, but patients typically find that it's worth that. It gives them insight. Some include osmolarity in addition to the Keratograph, but the point is there are many ways to kind of look at that from an ROI, but just even the dry eye clinic itself will do it. So we've got only about a minute left. So real quickly, What one piece of advice would you give to a practitioner starting a dry eye specialty practice in less than 30 seconds each? Crystal?
Screen everyone. Start tomorrow.
Tom? That was even much faster than 30 seconds. Good job.
Get a game plan. Don't just go into it half-cocked. Don't just go out and buy a toy. You really have to have a way to be able to gain that buy-in, and that's where, as Crystal said, Keratograph really shines there.
Yeah, and I agree. I think that the key is really you've got to get into it, get educated, take the time to look for patients, eye screening with your front office staff, or in many ways that you can. You'll be surprised at how many of these patients exist, how fast it grows your practice. Know what to look for, but don't make it complex. I think we spent too much time thinking there's too many things we have to do and too much involved. We need to really simplify it. I always love the quote by Mark Twain that said, if I had more time, I'd have written a shorter letter. And I think, you know, for years, I wrote the long letter in dry eye when I started in the late 90s. And now it's gotten to where it is a very quick, very simple, very straightforward approach. And I think the Keratograph will help you get there a lot quicker. Michelle, we're right at the hour. So I don't know at this point if I'll hand it back to you to either close us out or to next steps if you want, if you have questions that are really, you know, pertinent that we need to answer. I'll be glad to do that with the group here, or we can, you know, right at the hour, we can certainly call it a night.
I think we will go ahead and end the webinar. If you do have any questions, you can send them into application@oculususa.com, and I'd be happy to pass those questions on to our panelists here and have them reply back. I wanted to thank everyone in attendance tonight. Also, if you missed part of the webinar or if there's anything you would like to go back and review, you will receive a link to the recording within the next couple days. Thank you for everyone in attendance, and thank you, Dr. Karpecki, Dr. Brimer, and Dr. Weshefsky for your excellent presentation.
Thank you. Good night.
Thank you.
Night.
Have a nice night.
And this concludes the presentation. On behalf of Oculus, we wish you all a good night.